Rosalind Tatum was sitting at her kitchen table in Boise, Idaho, on a Tuesday morning in February, holding a bill she read 4 times because she was absolutely convinced she had misread it. She had not. The bill said $41,312, due in 30 days. She was 67 years old. She had worked 31 years as a master electrician. She had Medicare. She had a Medicare Advantage plan she had been enrolled in for 3 years and had never once had a single claim denied. And the hospital stay that triggered this bill, the one that put her husband in a bed for 4 nights after he slipped on the back steps, that hospital stay was covered. She was certain of it. She had called the plan before he was even discharged. The representative told her he was covered. What nobody told Rosalind, and what Medicare did not send her a letter about, is that there is a classification buried inside every hospital admission that has nothing to do with how long you stayed, how sick you were, or how comprehensive your coverage is. 2 words. And those 2 words just cost Rosalind Tatum's family more than $40,000 out of pocket. I will come back to her story in just a moment. But first, here's the part that should make you genuinely angry. 5 specific things inside Medicare changed in 2026. One of them is genuinely good news for retirees managing expensive prescriptions. One will blindside people who had no idea their income quietly pushed them into a surcharge bracket. And one of them, the one that is already costing families tens of thousands of dollars across this country, is a loophole so obscure that most physicians do not even think about it when they are filling out your admission paperwork. In a few minutes, I will also tell you about Eugene Holcomb from Locke, Texas. Eugene was a retired social worker, bringing in about $68,000 a year in retirement income. Nothing unusual on paper, nothing that would raise any flags. And then one financial decision he made in 2024 triggered a Medicare surcharge he is still paying today. What happened to Eugene permanently changed the way I think about retirement income planning. This video is for educational purposes only and is not tax or financial advice. Please consult a qualified professional before making any decisions about your specific Medicare situation. If you are not yet subscribed, take 2 seconds and do that now. I cover these rule changes the week they matter, not 6 months later when the damage is already done. By the end of this video, you will know exactly which 5 Medicare rules changed in 2026, which one requires action before December 7th of this year, and how to protect yourself from the one that can silently drain $40,000 from your retirement savings without any warning at all. Rosalind's story, the 2 words that changed everything. Rosalind Tatum retired in Boise, Idaho in 2021 at age 62. Her husband, Dale, was 64 and still doing some part-time electrical contracting work. They had 2 adult children, one in Portland and one still nearby, and they had downsized to a smaller house near the river when they retired. Their combined retirement income ran about $62,400 a year between Dale's part-time earnings, Rosalind's union pension, and Social Security she had started early. They were comfortable, not wealthy, but prepared. They had been on the same Medicare Advantage plan for 3 years. Not a single claim had ever been denied. In January of 2026, Dale slipped on the back steps where ice had not been cleared and was transported by ambulance to the hospital. He had sustained a compression fracture in his lower spine, serious enough that the doctors kept him for monitoring and treatment planning, 4 nights in the hospital, pain management, physical therapy assessments, a neurology consult. When Rosalind called the member services line from the waiting room, the representative told her the hospital stay was covered under their plan. But here is where it gets significantly worse. What nobody told Rosalind, and what the hospital paperwork did not make obvious, is that Dale had been admitted under observation status, not inpatient status. Observation status, inpatient status. Those 2 phrases sound nearly identical to any normal person sitting in a hospital waiting room at 11 o'clock at night. They appear to mean the same thing. But the difference between them is the difference between a covered hospital stay and a bill for $41,312. That is $1,377 per day for 30 days of skilled nursing care that Medicare did not cover. Not a single day, and $344 per day for the first 20 days that Medicare Part A would have covered completely at 0 cost to the patient if Dale had been classified as inpatient. All of it came down to 2 words on a form that nobody explained to Rosalind before her husband was discharged. Why does that classification matter so much? Under Medicare Part A, skilled nursing facility care is only covered after what is called a prior qualifying hospital stay. That means a minimum of 3 consecutive days recorded as an inpatient admission. Not 3 days in a hospital room, not 3 days under a physician's active care. The record has to specifically say inpatient. 3 consecutive days. When the record says observation instead, those days do not count toward that threshold. 0 qualifying days means 0 skilled nursing coverage. Rosalind's Medicare Advantage plan followed Medicare's own coverage rules, as all MA plans are legally required to do. They denied the skilled nursing facility claim. She appealed, she lost. She retained a patient advocate. The advocate confirmed that the admission had been correctly coded as observation. The rule was the rule. There was no procedural error to challenge. Here is what Rosalind could have done differently, and what you need to know before you are ever in this situation. Under the Notice Act, a law passed in 2015, hospitals are legally required to notify patients who are under observation status for more than 24 hours. That notification comes in the form of a document called the Important Message from Medicare. When you receive that document, you have the right to formally request reconsideration. You can also ask the attending physician directly whether the clinical facts of the case support reclassifying the stay as an inpatient admission. The physician has to document clinical necessity, but if the medical facts are there, reclassification can happen. It does happen. The critical window to make that request is while you are still in the hospital. Once you are discharged, the path to reclassification becomes significantly more difficult and significantly less likely to succeed. The single most important takeaway from Rosalind's story is this. If anyone in your family is ever admitted to a hospital, your very first question, before you sign anything, before they settle into the room, before you fill out a single form, is this. Is this an inpatient admission or an observation stay? Ask it out loud. Demand a clear, direct answer. Write it down. That question is worth $41,000. Why most retirees never think to ask. You are probably thinking the logical response is simply to stay alert and ask the right question, and that is absolutely correct. But here is why the vast majority of retirees never do it. They do not know the question exists. The observation status classification has been embedded in Medicare for decades. It started as a billing mechanism hospitals use when a patient's clinical picture does not clearly meet the threshold for a full inpatient admission. There is a gray zone in hospital medicine, especially around falls, fractures, cardiac monitoring, and infections, where the physician is actively watching and evaluating rather than treating a clearly defined acute event. In that gray zone, observation status is frequently the default classification, not because it is the right outcome for the patient, but because it reduces the hospital's audit exposure under Medicare's payment rules. The hospital's financial incentive and the patient's coverage interest are not aligned. They point in directly opposite directions. Who does this affect most? It affects retirees who experience falls, fractures, cardiac monitoring events, medication adjustments, and mental health evaluations. Those are precisely the kinds of hospital stays that most frequently lead to skilled nursing facility needs afterward. The same admissions most likely to be coded as observation are the same admissions most likely to be followed by the kind of post-acute care the 3-day inpatient rule was designed to cover. The trap is almost perfectly engineered to catch the people who need the coverage most. If you or a family member is ever in a hospital and you receive the important message from Medicare, read the entire document carefully. If it indicates you are under observation status, ask to speak with the attending physician about whether the clinical picture supports reclassifying the admission as inpatient. This conversation can happen. It does happen. And in some cases, with the right clinical documentation, the classification gets changed before discharge. But you have to ask before you leave the building. Eugene's story, the surcharge he never saw coming. Now let me tell you about Eugene Holcomb, because his situation is fundamentally different from Rosalind's in an important way. Rosalind was hit by a rule she had never heard of. Eugene was hit by a rule he genuinely believed did not apply to him. Eugene Holcomb is 71 years old and lives in Locke, Texas. He retired in 2019 after 32 years working as a county social worker. He was widowed in 2022 when his wife passed after a long illness. He has 3 adult children and 6 grandchildren. He makes it to every school event he possibly can. He told me once that the entire point of retiring when he did was to be present for the things he had missed for 30 years of shift work and overtime. And that is exactly what he has been doing. Eugene's retirement income in a normal year runs approximately $68,300. Social Security, a modest county pension, and some interest income from a CD ladder he spent 20 years carefully building. Nobody would look at Eugene Holcomb's financial situation and categorize him as a high earner. But in 2024, Eugene sold the house he and his late wife had purchased together back in 1987. He had paid $63,500 for it. He sold it for $416,200 in 2024. That is a gain of $352,700. As a single filer, he was eligible for the $250,000 primary residence capital gains exclusion. That reduced his taxable capital gain to $102,700. Add that to his normal retirement income of $68,300, and his total modified adjusted gross income for 2024 landed at approximately $171,000. And here is the part Eugene had absolutely no idea about. Medicare does not look at what you are earning this year to calculate your premiums. It looks at what you earned 2 years ago. Your 2026 Medicare premiums are based on your 2024 tax return. That is the IRMAA lookback, the income-related monthly adjustment amount. At $171,000 in 2024 income, Eugene landed in the third IRMAA surcharge tier for 2026. His Part B premium in 2026 is $481 per month. The standard rate is $185 per month. Eugene is paying $296 more per month than a retiree with the exact same health situation and the exact same coverage, simply because his 2024 income was elevated by a one-time house sale. That is $3,552 per year. That is $296 walking out of his Social Security deposit every single month in 2026 for income from a house sale that is long since completed and long since spent or reinvested. The house sold in 2024. That money is gone, but the surcharge followed him 2 years later, and it will continue into 2027 as well. Could Eugene have avoided this? Maybe not entirely. The capital gain on that house sale was real, and the tax consequences were real regardless of IRMAA. But here is what he did not know. The Social Security Administration administers a formal appeal process specifically designed for situations like his. It is called the life-changing event reconsideration. If your income drops significantly since the year that triggered the surcharge, and if that drop is connected to a qualifying event, which includes the death of a spouse, retirement, divorce, or a meaningful reduction in work income, you can formally request that Social Security recalculate your IRMAA using a more recent tax year rather than the standard 2-year look-back year. The form is SSA Form 44, the Medicare Income-Related Monthly Adjustment Amount Life-Changing Event Form. It is available directly on ssa.gov. Eugene qualified. His wife had passed in 2022. His 2025 income, with the house sale behind him, was back to his normal $68,300 range, well below the first IRMAA threshold of approximately $106,000 for a single filer in 2026. He could have filed SSA Form 44 and requested that Social Security base his 2026 IRMAA on his 2025 income rather than 2024. His surcharge in 2026 would have been $0. He did not know the form existed. He paid the surcharge. The full IRMAA tier structure. Know where you stand. Let me give you the complete picture so you understand the full scale of what is at stake. For a single filer whose look-back year income crossed $106,000, you are in the first IRMAA tier. The second tier begins around $133,000 for a single filer. The third tier starts around $167,000, which is where Eugene landed. The fourth tier begins around $200,000. And at the top tier, above $500,000 for a single filer, your Part B premium alone runs close to $629 per month per person. A married couple, both sitting in the top IRMAA tier, is paying nearly $15,000 per year in Part B premiums alone, before a single other healthcare cost enters the picture. One Roth conversion that runs larger than planned. One home sale. 1 year where required minimum distributions ran higher than expected. That is all it takes to push you into a higher IRMAA tier for the next 2 years. SSA Form 44 exists. You just have to know to file it. The Part D drug cap. Good news with a hidden cost. Here is the change that most retirees are getting at least partially wrong. When they hear about the $2,000 annual out-of-pocket cap on Medicare prescription drug costs, they assume their drug expenses just went down across the board. And for some people, they genuinely did go down in a meaningful way. If you take high-cost specialty medications for conditions like rheumatoid arthritis, multiple sclerosis, or a serious chronic illness, the $2,000 cap that came from the Inflation Reduction Act is the most significant improvement to Medicare drug coverage in years. Under the old structure, there was no ceiling at all. A retiree managing a serious condition could spend $5,000, $6,000, or considerably more in a single year just on prescriptions. The cap ends that exposure. That is a real and substantial benefit, and I want to be completely clear about that. But here is what most people are not being told. The $2,000 cap applies to your out-of-pocket spending. It does not mean drug plans are paying less in total costs. It means they are absorbing significantly more. And insurance companies that absorb more cost do not leave that expense sitting on their balance sheets. They pass it through to monthly premiums. Across the Part D market, monthly premiums have climbed since the cap took effect in 2025. If you have a Part D plan and you have not carefully reviewed your monthly premium in the last 12 to 18 months, there is a very real probability you are paying more per month right now than you were before the cap existed. Here is where the math goes sideways for a very large group of retirees. If your prescriptions are primarily generics and your total annual drug spending runs under $1,000, the $2,000 cap will almost certainly never apply to you. You will not come close to it. But the higher premium applies to you every single month regardless of your drug costs. For that group, and it is a substantial group, the drug plan reform delivered a benefit they will never collect and a cost they are already absorbing every month. This is precisely why open enrollment is not a formality. It runs from October 15th through December 7th every year. That window is your one opportunity each year to compare what your current plan charges against what alternatives actually cost for your specific medications in your specific zip code. The comparison tool is at Medicare.gov. You enter your prescriptions, your preferred pharmacy, and your location. The tool shows you the projected annual out-of-pocket cost for every plan available to you. It takes approximately 20 minutes. Skipping it can cost you several $100s per year because Part D plans in the same zip code can carry dramatically different premium structures for identical medications. Some plans are absorbing the cost impact from the new cap far more aggressively than others. The only way to know which situation you are in is to run the comparison. And here is the pattern that costs retirees the most. They look once when they first enroll in Medicare, select a plan that looks reasonable at the time, and never revisit that decision again. The plan that fit your prescriptions and your budget in 2022 may not fit either of them in 2026. Your medications may have changed. The plan's formulary may have been restructured. Pricing tiers on specific drugs may have shifted. This is a comparison you should run every single year before December 7th. Every year, not every few years. Otis's story. The prior authorization delay that cost 11 months. Let me tell you about Otis Buchanan, because his story is the one in this video that I think stays with you longest. Otis Buchanan is 74 years old and lives in Augusta, Georgia. He spent 30 years as a longshoreman, genuinely hard physical work done in Georgia heat for 3 decades. He retired in 2015 at 63. He had been divorced in his 40s and remarried about 8 years ago, a woman named Ranita who came with 2 children of her own. Between Otis's 4 children from his first marriage, Renata's 2, and the grandchildren that keep arriving, the holidays in Augusta are loud and packed and full of life. He loves that. He spent 20 years working shifts that kept him away from dinner tables and school recitals and back-to-school nights. In retirement, he finally got to be present for all of them. Otis had been enrolled in a Medicare Advantage plan for 6 years when this happened. He had chosen it specifically for the low co-pays and the built-in dental benefits. For 6 years, it had performed exactly the way he expected, every claim handled correctly and without dispute. In late 2024, Otis began experiencing serious knee pain, the kind that wakes you up at 2 in the morning and will not let you fall back asleep. His physician diagnosed severe osteoarthritis. The joint had deteriorated to the point where a total knee replacement was the medically appropriate next step. Surgery was scheduled. Otis completed all of his preoperative work. He received medical clearance. His labs were done. He was 2 weeks from the surgery date. Then the Medicare Advantage plan sent a letter. Prior authorization denied. The plan stated the procedure required additional documentation, demonstrating that conservative treatment options had been sufficiently exhausted. Otis had already completed 6 months of physical therapy. He had received 3 cortisone injections. His orthopedic surgeon had written a formal letter stating the procedure was medically necessary. The plan said it needed more, and here is where it becomes worse than simply a frustrating administrative delay. The plan required Otis to complete an entirely new, full course of physical therapy before it would reconsider the authorization request. 4 additional months. During those 4 months, Otis's condition deteriorated. The reduced mobility led to weight gain. The additional weight increased the load on the already damaged joint. The increased load accelerated the structural breakdown inside the knee. When he finally received authorization and underwent surgery in early 2025, his surgeon told him directly that the outcome would have been measurably better and the recovery meaningfully faster if the procedure had been performed when it was originally scheduled. The prior authorization delay did not save Otis money. It cost him 4 months of escalating pain, a more complicated surgical result, a longer and more demanding rehabilitation process, and the full out-of-pocket costs of the additional physical therapy and injections the plan required before it would reconsider. He also lost 11 months of the active retirement he had spent 30 years working toward, 11 months of getting down on the floor with grandchildren, 11 months of golf Saturdays he had been planning in his head since the day he filed his retirement paperwork. 11 months. That is not a paperwork dispute. That is his life. What changed and what your rights are. In 2024, CMS, the Centers for Medicare and Medicaid Services, finalized rules requiring Medicare Advantage plans to apply the same coverage criteria as original Medicare when making prior authorization decisions for certain medical services. The intent was explicit: stop plans from applying internal standards that are stricter than Medicare's own coverage rules in order to deny care that Medicare itself would cover. That regulation was supposed to protect retirees like Otis. The problem is that requests for additional documentation are still widely used as a practical mechanism to achieve delay without technically failing the coverage standard test. And while CMS gained broader enforcement authority under those rules, the gap between the regulatory standard and the actual practice in individual claims has not closed as completely as the regulation implied it would. Your rights, if this ever happens to you, are worth knowing before you are sitting at a kitchen table holding a denial letter. If your Medicare Advantage plan denies a prior authorization, you have the legal right to file an internal appeal. File it immediately. Do not wait. If the standard review timeline would seriously jeopardize your health or your ability to regain maximum function, you can request an expedited appeal. The plan is legally required to respond within 72 hours, not 7 business days, 72 hours. Your physician needs to submit documentation supporting the medical urgency of the request. If the internal appeal fails, you then have the right to request external independent review through the independent review organization designated by CMS. These rights exist in federal law, but they require you to know about them and invoke them yourself. The plan will not walk you through the process. Otis eventually had his knee replaced. He is doing well now. He made it to his granddaughter's spring recital and told me it was the first time he had stood through an entire performance without leaning on something for almost 2 years. But those 11 months, nobody gives those back. The complete picture, all 5/20/26 Medicare changes. Let me bring everything together in one clear summary before you leave this video. Change 1, the observation status versus inpatient classification trap. Ask the question before anyone is discharged from a hospital. Is this an inpatient admission or an observation stay? That question is worth tens of thousands of dollars. Change 2. The IRMAA 2-year lookback surcharge. One-time income events, a home sale, a large Roth conversion, an unusually high RMD year can push you into a surcharge tier 2 years later. If your income has since returned to normal and a qualifying life-changing event contributed to the drop, SSA Form 44 exists and can eliminate the surcharge. Change 3. The Part D $2,000 out-of-pocket cap. Genuinely beneficial for retirees on high-cost specialty medications. A potential net negative for retirees whose prescriptions are primarily generics, because premium increases may exceed any benefit they would ever see from the cap. Run the comparison at Medicare.gov before December 7th. Change 4. Prior authorization denials in Medicare Advantage plans. The 2024 CMS rules tightened the standard, but delays through additional documentation requests remain common. Know your rights. Internal appeal, expedited appeal within 72 hours when medically urgent, and external independent review if the internal process fails. Change 5. The full retirement age milestone for anyone born in 1960 or later. Claiming at 62 now means a permanent 30% reduction compared to waiting until 67. Understand exactly how your claiming age affects your lifetime benefit before you make that decision. If someone you care about thinks Medicare is something that just takes care of itself, send them this video. What they learn here could protect thousands of dollars they spent decades earning. Hit like if this helped you. Leave a comment and tell me which of these 5 changes caught you completely off guard. I read every single one. That is all for today. Protect what you earned. Subscribe to Senior USA Hub for more content that keeps you informed, prepared, and protected.